Hello everyone. Now today I am going to discuss some routine procedures in our medicine wards. You know that ascitic fluid aspiration, pleural fluid aspiration, and CSF aspiration. CSF is lumbar puncture tapping, and CSF collection is done in every day in our medicine ward, and it is these are some routine procedures. Now, after taking the fluid in vials, so you need to analyze the disease. We takes we collect the fluid for analysis and for reporting and to diagnose the disease properly. So now I had in my previous videos I had uploaded the causes of lectures on jaundice and portal hypertension. So there I had discussed how to approach a case of ascites step by step, and what causes of ascites step by step. And rather than that, I had also uploaded videos how the CSF is collected from lumbar puncture, and what is the procedures to be followed here, and how pleural fluid is collected in case of pleural effusion. These videos were also uploaded previously. You may see there. So now I am going to start how to analyze this fluid. At first, I am going to start with ascitic fluid. So when we are collecting the ascites fluid, so we will send the ascites fluid as well as blood sample. Blood we will also send LFT. There we'll send the SGOT, SGPT, and especially albumin level, well, and protein level. Okay, and in ascites fluid we will send for cell types, cell count, protein, albumin, sugar. And in our country, this is as we are living in a tubercular prone country, we will send ADA, and as well as we may send CVNet. So sorry. So to analyze the ascites fluid, we will first check the SAG. So SAG ratio. So what is SAG? SAG is the difference between serum albumin and ascites albumin. So to analyze the ascites fluid and evaluate the disease, so we need to send the serum blood sample also. So here we will take the albumin and serum, and here we will take the albumin of ascites fluid. After this, getting this SAG ratio, if the SAG ratio is greater than 1.1, so means it is the high SAG ascites. So here it is significant. There is the portal hypertension. Portal hypertension is there, and if SAG ratio is less than 1.1, so there is no portal hypertension. Tension is absent here. Causes of low SAG ascites are biliary leakage, nephrotic syndrome. In you know that nephrotic syndrome, there is a huge amount of generalized anasarca is there, as well as there is a uh, ascites is also there. In nephrotic syndrome, you know that large amount of protein loss is there, so colloidal osmotic tension is reduced. One day I will tell about one day I will discuss about colloid osmotic tension and anasarca. But now that is the scene, and so in nephrotic syndrome there is the low sag ascites. Rather than that, there is the peritoneal CA and pancreatitis and tuberculosis. There is the low sag ascites may be there. So if the sag is greater than 1.1, so it is the high sag ascites. Then we will check for ascites fluid for total protein. So if the ascitic fluid is greater than 2.5, then there are some DD. It may be due to the congestive heart failure. It may be due to the early boot cherry. It may be due to the IVC obstruction and sinusoid obstruction. So most of the causes are extrahepatic. Post hepatic. And if the high sag if the total protein value is less than 2.5 among these high sag ascites, there are also some causes. There may be the cirrhosis, there may be the liver mets, and it may be late Budd-Chiari. In CHF, CCF, you know that there will be raised NT-proBNP level, and if it is the right heart failure, so if it is a right heart failure, you will see the trait of raised JVP. There is pedal edema and orthopnea. Raised pulsatile JVP and only raised JVP is seen in SVC obstruction. Raised pulsatile JVP is seen in right heart failure. Okay. In IVC of inferior vena cava obstruction, there is also high sag, high protein ascites. And in case of the cirrhosis, you may see that in blood you can get the Apri score. You can get from you can evaluate from Apri score. Apri score, there is the AST by upper limit of this AST and by platelet count into 100. So if the Apri score is more than 1.4, so you will suspect that there is a fibrosis is there. And in case of liver cirrhosis, as albumin is synthesized from liver cells, so albumin will be decreased and globulin will be increased, so AG ratio will be altered. And after the and in then we will go for fibroscan, and fibroscan we will see the liver cirrhosis, and in USG we will see the sunken liver. And in USG, in if liver it's in liver mets, we will see some irregular liver surface, and in clinical findings also we can see some irregular liver surface. And if the primary origin is another part, we will see we can notice that malignancy, lymphadenopathy, the cachextic look of the patient, etc. Okay. In late Budd-Chiari syndrome, also we can see that high sag, low protein. Okay. And in nephrotic syndrome, we can see that there is a nephrotic range proteinuria in urine ACR. Urine ACR, we can see the nephrotic range proteinuria more than 3 gram per day. And in pancreatitis, we can see there is the elevated amylase lipase. And in USG also we can see the pancreatitis, USG and CT scan. Peritoneal CA can be evaluated, and if we suspect that for peritoneal fluid CA, the level will be decreased, and we will send for M cell, and there we will get the malignancy. Ascitic fluid will send the ascitic fluid for M cell, and then we'll see the malignancy. Okay, so thus the evaluation is done. So at first we need to get the sag ratio. If the sag ratio is more than 1.1, then portal hypertension is there. So then if the if the portal hypertension is there, then we will look for ascitic fluid protein. If the ascitic fluid protein is more than 2.5, there are some DDs like chronic congestive heart failure, early Budd-Chiari, IBC obstruction, and sinusoidal obstruction. If there is the if high sag and low protein, if less than 2.5 gram per dl, then there are also some DDs like cirrhosis liver, and there is the liver mets, late Budd-Chiari syndrome, and if there is less if the sag is less than 1.1, or there is a no portal hypertension is there, and there are some DDs like nephrotic syndrome, pancreatitis, peritoneal CA, and tuberculosis. So and this is the basic investigation, and then after that we'll correlate and get what we'll suspect that disease, we then will do the further investigation that I described. Now I will tell how to evaluate a case of pleural fluid. So, if a pleural effusion is there, it has also some causes. I had discuss it in some different video. And if after getting this, we take the aspirate the pleural fluid from the upper border of the lower rib, from that space and upper border of the lower rib, so that there no neurovascular bundle is injured here, because a neurovascular bundle passes through the lower border of the upper rib. Okay. After we collect the pleural fluid is also sent for cell types, cell count, protein. Here only protein, no albumin is sent. LDH, sugar, and in our country, gram stain, Zn stain, CBNAT, and ADA. You know that our country is a tubercular prone country, so these are also needed. But as the pleural fluid in tubercular effusion tubercular if the primary causes is primary tuberculosis in lung, and as pleural effusion occurs for that then it is then we get no AB acid fast bacilli, and CBNAT also becomes negative in the pleural fluid, because it occurs due to hypersensitivity. Okay, then we need to diagnose the tubercular pleural effusion by exudative lymphocytic predominant and ADA, high ADA value. Okay, if, that I am discussing now. And rather than pleural fluid, we will also send for blood LDH level and serum protein level. Okay, because here we also need to compare. Then if the pleural fluid is calculated, if the then do these two reports are came, then if the pleural fluid pleural fluid protein and versus serum protein ratio is more than 0.5, or pleural fluid LDH level by serum LDH level is more than 0.6, or pleural fluid LDH level is more than 2/3 of upper limit of serum LDH. If any of the three is present, we will tell it exudative. If not, then transudative. So some causes of the transudative pleural effusion are there, like CCF, congestive cardiac failure. In congestive cardiac failure, there is you may see the bilateral pleural effusion also. Okay, cirrhosis of liver, and in massive ascitis, there you can also get bilateral pleural effusion at the ascetic fluid passes through the channels and of diaphragm and accumulates in the pleural spaces, and nephrotic syndrome also. In nephrotic syndrome also, whole body swelling is occurs. I had told you how CCF is diagnosed, and here CCF is antiproBNP is there. By the way, I am telling the classical signs of right heart failure and left heart failure. Right heart failure, you know that raised pulsatile JVP and tendered pulsatile hepatomegaly and bipetal pitting edema. In left heart failure, you can see the S3 gallop and orthopnea, and left heart failure, it you can see the basal crepes on in lung, and there you can see orthopnea and S3 gallop. Okay, now I am coming to the Light's criteria. It is pleural fluid is diagnosed by Light's criteria. Okay, if there is the exudative, if exudative effusion is there, then we will check for pleural sugar level, cytology, cell types, and cell count. Okay, another thing I want to tell that in CCF there is the NT-proBNP value of pleural fluid is also raised. So if we suspect the CCF, we may send the NT-proBNP value also. So then we will say the pleural fluid sugar. So if the glucose is less than 60, there is some causes. There is some cause of there may be the cause of the malignancy. There may be cause of the rheumatoid factors, and there may be cause of the bacterial infection. In bacterial infection, we see the polymorphs nucleus, and polymorphs nucleotide means WBC cell will be increased in pleural fluid. In malignancy, you can see the M cell will send for M cell, and M cell then will detect the malignancy. And in a rheumatoid factor also, we can see the RA factor is raised in pleural fluid. Okay, and if the pleural fluid is not decreased, if the pleural fluid is greater than 60, then we will first check for pleural if there is any pulmonary embolism or not. For pulmonary embolism, we will do spiral CT. Spiral CT or CT angiography we may also done, but spiral CT is seen in ECG. Is we can see as QT3, and most common feature in ECG is sinus tachycardia. Okay, and for pulmonary embolism, we can to detect clinically, we can suspect by Will's criteria. Okay, and for we will do just a spiral CT. If we found nothing in the spiral CT scan, we will go for tuberculosis and AFPs for finding tuberculosis. So if we will see that if the ADA value is high or not, if the CV naught is positive or not, or if AFB bacilli is present in here or not. In we had sent here, so but most of the cases in primary pulmonary tuberculosis or the pleural effusion is present, there we get no bacilli, and CB naught is also negative here. So we get here only exudative lymphocyte predominant and high ADA value. So we need to send these fluids in first attempt, because this investigation in first attempt, because you cannot, because it is a invasive procedure, patient may feel pain, and there are some risk factors that you may, during the punctures you may injure any vessels. You may, there may be be insertion of the air in the pleural cavity. There may be the pleural fluid, pleural effusion may turn into hydropneumothorax like this. So you may be cautious. So in first attempt you will send this uh, investigations. Okay, so if that is also not found, if tuberculosis is also not found, you will wait. If the tuberculosis is found, you will give him the ATD. But if the tuberculosis is also not found, you will wait, and you will wait if they improve for the symptoms or not. In if the symptoms is not improves, you will go for thoracocentesis. Okay, now I will tell for about analysis of the lumbar puncture fluid. Means CSF is collected by lumbar puncture. It is very sterile thing, and it is as it is brain is our main part, and lumbar puncture should be taken very cautiously. And before doing lumbar puncture, you need to check the CSF pressure by seeing the papilledema. You know that papilledema is seen by ophthalmoscope. If there is there is a raised ICT, so your papilledema is seen, means any mass is there or any hemorrhage out there. And another thing is that subarachnoid in case of subarachnoid hemorrhage, you can it mimics like meningitis. So before that we used to do at least we used to do the fundoscopy for to rule out the papilledema, and we do a CT scan also for rule out if any subarachnoid hemorrhage is also there or not. In meningitis cases, you can see there is a fever, there is a, you can see there is a neck rigidity, Burzynski sign, and Carnita signs is also there. And meningitis is a very severe infection of the brain, so you need to evaluate it by analysis the CSF fluid. So lumbar puncture is done. I have this described in the previous videos, where the lumbar puncture is what is the site of lumbar puncture and how lumbar puncture is done, and it is also seen in live. Then you will need to found if it is you need to know the normal value of CSF. So CSF WBC, in CSF WBC is less than 8, and there is if the per CUMM, if the protein is 15 to 45 milligram per DL, and glucose is 50 to 80 milligram per DL. Oh, another thing I had forgotten to tell, in CSF, CSF you need to send for cell types, cell count, protein, sugar, ADA, gram stain, Zn stain, and CBNet. Yes, tubercular meningitis is also common in our country. In CSF, you need not to send for blood fluid. Blood investigation need to send for other evaluations and monitoring the patients. But for diagnosis the cause of the meningitis, we need not to send for the blood. Blood may be sent later for any color sensitivity, any monitoring, but for CSF analysis it is not needed, like ascitis fluid analysis or pleural fluid analysis. So these are the normal values of CSF, and CSF is colorless, and WBC is less than 8 per, and sin protein is 15 to 40 A5, and glucose is 50 to 80 milligram per dl. In case of bacterial meningitis, patient feels very toxic, very fever, and patient feels severe headache also. Bacterial meningitis, CSF color become turbid. In here, WBC is very high, more than 1000 to 2000. Here protein is also raised, more than 200, and glucose value is decreased more less than 40 because bacteria has eaten the glucose. Then I will take for viral meningitis. Viral meningitis is quite sterile, and color is also clear. Fluid you can in bacterial meningitis, WBC is predominantly WBC is, you can see the neutrophil, means a polymorph type in bacterial meningitis. In viral meningitis, fluid color is clear. You can see WBC count less than 300, and most are lymphocyte predominant. Protein is also not much more. Protein is mild raised, and it will be under 200 milligram per dl, and glucose level is normal because virus do not destruct the CSF glucose level much more. In case of the tuberculosis meningitis, it is slight opaque, and there we can get the WBC count 100 to 600. Here also WBC count is raised moderately, but here is the thing that those are lymphocyte predominant, which different it from bacterial meningitis. And here also protein is raised. Protein is 50 to 300, and glucose is slightly decreased. In case of the fungal meningitis, because in some immunocompromised patient like diabetes, like some blood diseases, and some and HIV cases, the fungal meningitis is seen. Fungal meningitis WBC count is fungal meningitis is also, it is its color is clear, more or less clear. WBC count is less than WBC count is less than 500, and protein, but here protein is mild raised than 200, and but glucose is normal. Okay, yeah, you may get lymphocyte or pleomorph, or it is mixed. Okay, thus we evaluate these three fluids. Okay, thank you.